So it's not just simply, you know,
going to get you to talk about now, I think.
If I had known I could see my notes, I would have typed it all up. Oh, there's old notes in there.
Is there anybody you don't want the question from? I'm kidding.
Yes, actually. No.
So where's the clicker gone?
Yeah.
Somebody walk, you got it. Do you want to just try it very quickly? Yeah, it works.
Yeah.
Great. Well, good luck. Looking forward to this.
Thank you.
Okay, good morning. Thank you for returning promptly from the coffee break. This is a very prestigious prize lecture that you're going to have now. It's one of the really important prizes that the BNS invests in because it recognises excellence in our early career researchers. And it's also named after Professor Elizabeth Warrington. So Stephanie is our 21st Elizabeth Warrington Prize winner. And it's a great pleasure to welcome her here to give her lecture. But let me just give you a little bit of a background. So Stephanie is a Dondas principal investigator and research group lead at the Dondas and is an associate professor at Radboud University. She is the leader for language and communication themes spanning across the Dondas Institute for Brain Cognition and Behaviour, Max Planck Institute for Psycholinguistics, and the Centre for Language Studies at Radboud University. Her work, as we will hear, centres on neuroviability and its impact on cognition across different brain states, including health and disease. And Stephanie is also very engaged with public dissemination of science. So more about that in a moment. Just a mini bio. So Stephanie completed her undergrad in psychology at Salzburg in 2007. PhD at King's was completed in 2013 with periods of time spent abroad, Galway, UCL, Chicago and San Francisco. And Stephanie and I were just saying that it's so nice to see so many people from these different places that she's worked here today. And that's one of the positives of the BNS, is bringing people from all of these backgrounds together and locations. So that's the that's the front of house. Now I'm always interested in the backstory that brings individuals into neuropsychology, and doing a little bit of research on Stephanie, I found that her aha moment occurred in the morgue. I've never had one of these before. It's usually I want to help people, or I worked in a as a volunteer. But anyway, so I think so it was in the morgue that Stephanie first realised that there are differences between what people's brains look like, and I think we will be maybe not returning to that direct theme, but it gives us a bit of a context for you're interested in the neuroanatomy and viability. So it's a great pleasure to welcome you, and look forward to hearing about mapping the neurobiology of language from anatomy to the clinic. Thank you, Stephanie.
Thank you very much for that lovely introduction. I was very worried what you find online. But that story is actually true. And the story behind that bit is that I used to work in a neurological clinic, and I wanted to get more experience being a psychologist. So I asked the doctors if I can follow them around, and they were all too busy to take me on board, except for one person who said, no one ever wanted to be here. So if you want to come, be my guest. and that was the pathologist. So that's how I ended up in the morgue. Thank you for the introduction. Thank you also to the BNS. It's such a great pleasure to be back in London and to be receiving this very prestigious award. It means a lot, and to see many of the previous awardees in the audience is also a great honor. Now, as you can see from the title, we're going to talk about language, anatomy, and the clinic. But I also have to warn you, there's going to be some interactive elements. So if you thought you could just sit back and relax, not this hour. But some of the times you will see a link to YouTube on the slides. That just means that for this particular slide, there's an entire dedicated talk online. So if you want to deep dive, there is a lot more material online. Today, I'm going to give you an overview of the last decade of our work. Starting with the last time I was here to give a talk, which was in 2015, the BNS autumn meeting, where Katrina Fotopoulou and Paul Jenkinson organized a Oxford-style debate on the motion that human lesion neuropsychology will inevitably be replaced by neuroimaging as a research tool for understanding cognition. Now, debates are only fun if you really go all in. So we did on both sides. You can guess which side I was arguing for. And in the heat of the debate, we were called mini Geschwins with fancy toys. Nearly 10 years after, I'm still not sure if this is an insult or a compliment. But we then basically agreed that, yes, we do have fancy toys, but really, if they prove to be clinically meaningful, then there is some value in using them. So what I'm going to do today is I'm going to show you all these fancy toys and tools that we developed over the last decade and give you some indication of how we applied them in the clinic and what we can do with them. Now, I said from anatomy to clinic, so this is where you come in. Let's start with the anatomy bit. And a very simple question to all of you is, how many lobes does the brain have? And I just want a show of hands when I say a number you agree with. Ready? 1. People are already counting. 2, 3, 4. Discussion is allowed. 5.
Is this unilateral?
Good question. 6, 7. Anyone needs more numbers? That happened in the past as well. Okay, the interesting bit about this question is I asked this question to a range of audiences, and the answer is always the same. There's disagreement in the room. And the reason for that is that we changed our definition of how many lobes the brain has. So for those of you who thought it's 4, I'm sorry to tell you, you're stuck in the 19th century. For those of you who said it's 5, welcome to the 70s. 6 lobes since 1998. Now, you can discuss whether or not the parcellation is accurate, but that's the official anatomical nomenclature. Here we go. Now we know the anatomy of the cortex. Now, I thought I'd ask someone who should know better than me. So I asked Google the same question, and Google said 4 lobes. But I'm a very persistent person, so I just asked Google again in September last year, and it changed its mind. So now someone published a paper, and Google realized it's actually 6 lobes. Now, obviously, the last 2 years, we were all very busy talking to AI. No difference for me, so I asked ChatGPT. And ChatGPT was interesting because it depends on how often you ask it. So the first time I asked, it said 5. Then I just I love that absolutely no one moved. Okay. So I just repeated the prompt, and this time it said 4, and then I just repeated again, it said 6. So the lesson to be learned here is ChatGPT will give you the answer you want. You just have to be persistent. I also use that slide with my students to show them that writing an essay on anatomy with AI is not a good idea. They have to go in a library and open a book every now and then. Okay, So the confusion that we have in the field is also represented, not surprisingly, in the online tools that we use. Now the white matter. You have an idea where this is going, right? So who thinks there's 10 tracts in the brain? 20, 30, 40. Now you're all too shy. Right. I put you to ease. The answer is we don't know. And the reason we don't know is, well, there's actually many reasons, but what you see here is the white matter connectome or tractogram of the entire brain. And for the untrained eye, you see it's very difficult to identify individual bundles here and see the separation between them. Now, the reason that we don't know exactly how many tracts there are is because the way we define a tract might vary. So you can define it by the core of the tract, you can define it by the endpoints, and that will change the number of tracts that we have. And I'm going to give you examples of that in a minute. Mish wants to enter. Now, another thing that is very important to know about tractography that you're seeing here is that the visualization kind of implies that we can see individual axons in the brain. Now, our resolution is not good enough to do that. And this is just a fancy trick that was played on the software to make it look like axonal structures. But what you see is the directionality of water molecules. Now, whoops. Oh, it didn't update. Anyways, I'll come back to the slide that should be there later. It's like, what happened? Like half the talk on. How does the PC work? I'm a Mac person. Oh, interesting. Sorry about that. That goes here. No, that should be fine now. If you want to restart it.
Start from the beginning.
Yeah. Okay.
Is it moving?
Oh, I can make it move. Okay. Sorry about that. Right. So the difference in the tracts that we have, you can get an indication here. That's not an exhaustive list, but these are some of the white matter atlases that we have available, and they differ in the conceptualization of the white matter, and they also differ in the methods they use. Now, what you can see is that they range. So we have about 50, 48, 20, 60, and 68. Now, another thing to bear in mind here is that they're all quite dated at this point, and the world of tractography has dramatically moved on, so the algorithms are much better. Most of these atlases weren't able to resolve crossing fibers yet, so we have an underestimation of the white matter in the brain. Now, this has changed in 2016 with the Roshkova atlas, where for the first time spheric deconvolution was used that can actually resolve crossing, and you can see that we have more connections. But the point that I want to make here is that the results that you get are only as good as the atlas that you use. So when you choose your atlas, be mindful of what you're actually using, what the data behind it is. And I'm also happy to say that we're in the process of finishing a new atlas that now has 120 tracts. And Cesare Bortolami, who probably hates me at this point, had to manually dissect them all in the HCP dataset. And it took him about 4 months to do that. But as you can see, the result is quite stunning. And what we do in this atlas we also map the variability for every single tract, and you're going to have the maps, but also the individual TRK files to use. Right, that's that part. Now, the other part of anatomy and why we disagree how many structures there are and what they're called is because you can look at the anatomy in a different way. So we can look at the surface of the brain, the sulci, the gyri. We can slice through the brain and look at the deep nuclei, the white and gray differentiation. We can look at the connections and obviously at the bold signal projected onto the cortex. Now, obviously, it's all the same brain. You can do all of these types of looking at the anatomy using different sequences on the MRI, for example, but they all come with their own nomenclature. So if we look at the surface anatomy, for example, the precentral gyrus is the structure just before the central gyrus. Is very logical when it comes to surface anatomy. And in the functional world, the same structure would be called M1 or the motor cortex. Now, sometimes those don't match up, sometimes they do match up, but learning anatomy doesn't get easier if you think there's double the amount of terms than there's actually brain structures. Now, in terms of looking at the white matter, there's only two methods you have available. And one of them, as we heard, is postmortem. So you do Klingler postmortem dissections, it's called, where you go and work with the actual brain, and you carve away the surface of the brain to expose the white matter underneath. Now, the other method that we have is in vivo diffusion weighted imaging tractography, and the advantage is that this is in vivo, so you don't, right, you get the gist. But it's not only that you can study the living brain, you can also repeatedly look at the samples, and you can have much larger samples. So here's just a collection of papers where we combined the two methods to validate the tractography results. The first one is 2011, where for the first time those SLFs 1, 2, and 3 were described in the human brain. Then we have the inferior fronto-occipital fasciculus mapped in the cohort for the first time. U-shaped fibers, so these are very short connections between neighboring gyri. And you can also do this comparatively using different species. Now, I'm not going to go into detail, but very briefly, to do Klingler dissections, all you need is a well-prepared specimen, and this is the hardest to get. It takes about 3 months. And then you need a lot of patience to dissect the brain. In terms of the instruments, you can see it's nothing fancy. You find this in any standard hospital and university setting, and not necessarily, but preferably a microscope. Now, that's all I'm going to tell you about Klingler dissections, but if you want to know more, you're more than welcome to come and talk to me. And also, if you want to try it, shameless plug, there's a course in June where you can come and do some dissections with us in Switzerland. Now, coming to the language part of the talk. These are probably images you have seen in one form or another. And I want to spend the rest of the time that I have to show you why these models are incomplete and need updating. Now, let's start with cortical anatomy again. This is taken from Tremblay and Dick from 2016 in a paper provocatively called Broca and Wernicke are dead. And what they did in this study is they asked experts in the field where Broca's and Wernicke's area are. And what you can see is that there's many different configurations of where Broca's and Wernicke's were defined in the cortex by experts. And when we put it all together, then the biggest agreement for Broca's area was with 49%, area 44, 45, and for Wernicke, it's as low as 26%. So the point that I'm making here is that when we describe the anatomy, we should be precise, because if you say Broca, the person reading it may think of a different part of the brain. So being anatomically precise is important. Now, looking at the white matter, we have seen that language in the brain has extended beyond the classical arcuate fasciculus and is often reported as the dorsal and the ventral stream. And looking at the dorsal stream, we have the arcuate fasciculus, the 3 segments, and the fronto-aslan tract. And then I'm showing you where the tract is projecting to on the cortical surface. And what you can see is that the arcuate fasciculus is extending far beyond any definition that we've seen on the previous slide of Broca's and Wernicke's area, but it is hitting those areas that we would expect. Now, for the ventral network, that's quite a different picture. So here we have the inferior fronto-occipital fasciculus, we have the uncinate that hooks the anterior temporal lobe and the orbitofrontal cortex together, and we have the inferior longitudinal fasciculus. Now, the IFF is often associated with semantic deficits in brain tumor patients, but as we can see, it doesn't connect to any of the classical language areas that we would expect. So again, precision is key in that case. Now, there's more things that I don't like about this model. This is the next example. So what you see here is a representation of the visual and the auditory system in the brain. And you can see every box is a part of the brain and every line is a connection between these cortical areas. Now, we can all agree here that this is quite a complex network for vision and auditory systems. And if we agree that vision and auditory systems are this complex, then surely something as complex as language has to be a bit more complicated than that. Tractography has helped a great deal to map the extended language network. So the classical model from the 19th century is that we have this direct frontotemporal connection, the arcuate fasciculus, sensu stricto. Then in the early 2000s, Marco Catani described the indirect segment, the anterior and the posterior segment that relay in the inferior parietal lobe. And since then, many more tractography, but also clinical studies with direct cortical stimulation, TMS, and so on and so forth, identified a much more extended network that relates to language functions in the brain. Doesn't end there. I want to illustrate this using a couple of examples, and you may recognize a few people on this slide. Some of you may even recognize themselves. Anyone dares to make a guess who these people are?
Elizabeth Warrington Prize winners.
Thank you, yes, all of them. And I asked my student to make an average face of all the prize winners to show you what you need to look like to win the award. You ready? There you go. Now, there's a couple of things you can see here. One is that it actually worked. We see a face. That's good news. The algorithm did its job. But the other thing that we can see is that the face in the middle doesn't look like any of the individual people that won the award, nor do any of the individual people look like the average. And on top of that, the average doesn't even look like the original. Now, what you can nicely see here, and it's very easy to identify that using something familiar like faces, is that the average doesn't represent the individual. And it's plain obvious when you do this with faces. It's a lot less obvious when you do that with the brain. So this is the average MNI template brain. And we can see that some of the areas are less variable between us, and they end up with very sharp delineations. So that's here, for example, is a very sharp boundary for subcortical structures. But when we look at the temporal lobe, for example, there's a lot of variability and the template becomes a lot more smoother there. Now I'm going to show you two examples of the degree of variability that we can see. This is the motor cortex study done here at UCL, where the classical inverted omega sign to identify the hand area is not always an inverted omega. It can also be an epsilon or anything between the epsilon and a straight line. Now that's for the cortex. For the white matter, it's no different. These are two randomly drawn examples from a large data set that we have at the Donders Institute, healthy students. And I'm just going to point you to the uncinate fasciculus here, the hook that is in teal here, and it's barely visible in this student, and it's extremely prominent in this student. And these are healthy brains. Now, these are obviously hand-picked examples to illustrate my case, But we looked at this variability across the brain in a large cohort. And there's a couple of things that I want you to take away from this work. So on the top, you see the gray matter. On the bottom, you see the white matter. And the first point to take away is that variability across the brain is not the same across the brain. It's not homogeneous. Okay, so there's a degree of variability. Moreover, there is a gradient of variability. And we can see that nicely here, where the deeper parts of the brain in dark blue are less variable between us. And as you go more lateral, the variability increases. Now, this is important when you use an atlas, because if you're interested in subcortical structures, an atlas is fine. If you use an atlas for an area where you have a lot of variability, then it's probably not ideal. And even more importantly, when we bring this back to the clinic, there's a problem that the postdoc in my lab nicely illustrated here with a brain tumor patient. So in green, you see the brain tumor. In blue, you see the corticospinal tract. And he used an atlas and brought it into the patient space. And what you can see is that the atlas suggests the corticospinal tract should be here, when in fact it's completely displaced to the side. So the point here is that using an atlas in clinical populations is a very difficult endeavor, and you got to be careful when doing that. Okay, so now I'm showing you that we are different, our brains are different. Now the big question is, so what? Does it matter that we're different? And that's a study that we set out to do. It was supposed to be a pet project for a weekend. And Etta House, who's here today, and I ended up spending about a year on this study because there was 326 studies that looked at the variability of the anatomy and the variability in cognition. And this predates just about, we should have waited a year, just about predates ChatGPT. So we had to read all the papers. We couldn't just have them summarized. But what we learned from this study was quite surprisingly that most of what we know about the function of the white matter, we actually know from clinical populations. So you see that here, 45% of the studies were conducted in neurological and neurosurgical patients, 29 in psychiatric patients, and only 25% of the studies were conducted in healthy controls. The other thing that we learned is that we have some superstars in the field, like the corticospinal tract, and some tracts that no one cares about, like the acromiofrontal pathway. Now, there's various reasons for that. It's not just a lack of interest, but it's also that the tracts at the top are obviously the largest tracts in the brain, so they're way easier to dissect and see, even with a lower resolution scan. Now, the other thing that we learned is that the tracts are not equally important across the face. So the corticospinal tract is extremely prominent in neurology, but a lot less so in psychiatry and healthy controls, for example. Now, another thing that we learned doing this review is that we looked at a range of tracts. I think it was 69 tracts in that study, and I'm just going to highlight the arcuate fasciculus for you. And that is that the arcuate fasciculus is always considered as the language pathway. But actually, when you look at its correlations, then yes, it's primarily a language pathway, but it's also recruited for other functions like memory and attention, auditory, motor, and executive functions, for example. And this pattern is not unique to the arcuate fasciculus. We saw this for every single tract that we looked at. So the take-home message here is that there is no one tract, one function association, but that one tract can be recruited for various different functions. Now, the next question then is, if we are different and if it does matter in terms of cognition, what happens when you introduce pathology to the brain? And this is a study we did in London back in 2014, where I recruited acute stroke patients and followed them up longitudinally. And they had a language assessment in the acute stage and later on using the Western aphasia battery and also some imaging. And what you see here is a plot where on the x-axis, we have the size of the arcuate fasciculus in the healthy right hemisphere, plotted against the recovery 6 months after symptom onset. And I'm highlighting 3 patients here for you. Patient number 1, then down here didn't do particularly well 6 months after the stroke, and we can see that the arcuate fasciculus in the right hemisphere is rather small. Patient number 2, that's slightly better in terms of the recovery, and the arcuate fasciculus is better in the right hemisphere. And patient number 3, who according to the Western aphasia battery fully recovered, even though speaking to her you could still pick up some errors, had a really thick, nice connection in the right hemisphere. Now, the interesting thing about the study is that it's corrective for demographic and clinical data, which would have predicted about 30% of the recovery. And by introducing the variability in anatomy, we can boost that to nearly 60%. Now, another aspect that I was interested in was the classical disconnection syndrome. Disconnection meaning that you have two areas, they're connected, and you basically cut the wire. So it's a disconnection syndrome, in this case, conduction aphasia that is marked with repetition errors. So the comprehension of language is intact, the articulation of language is intact, but what doesn't work is sending what you heard to the frontal lobe to articulate it. Now, the classical model postulated that it's a disconnection of the arcuate fasciculus, the frontotemporal connection, and then with the emergence of CT imaging, that narrative slightly shifted to the inferior parietal lobe, reporting patients that had a lesion in the inferior parietal lobe without damage to the arcuate fasciculus, presenting with similar symptoms. So I was intrigued by that and I wanted to look at it. And that's when I teamed up with Marcel Mesolam in Chicago, who had the data from primary progressive aphasia patients and both the tractography and the cortical morphometry data to look at. Now, we did the 3 segments of the arcuate. We chose cortical areas from the literature and then ran the statistics with repetition deficits. And what we found was that there was absolutely no correlation with the arcuate fasciculus, but a correlation with the indirect segment that relays in the inferior parietal lobe. And when we split them up, that correlation was driven slightly by the posterior segment. Now, in terms of the cortical areas, after multiple comparison correction, the only area that survived was the posterior supramarginal gyrus, which is right here in the inferior parietal lobe. So what we concluded from this data is that after 150 years of conduction aphasia being a disconnection of the arcuate fasciculus, we took the arcuate out and proposed a new model whereby a lesion can occur along the network in the cortex or the white matter and will result in repetition deficits, but the flavor of the deficit will vary depending on where in the network that lesion occurred. Now, in this study, we combined tractography and cortical morphometry, but we're fundamentally interested in the function of the white matter. So it was time to branch out and also look at functional imaging studies. So in this particular study, what we did is we used functional imaging data that we had in Bordeaux on a reading task, did a classical analysis of fMRI, classical GLM. But what we also had was lesion data. So over 1,300 lesions from UCL, Parashka-Knachev provided them to us. We could derive the disconnection pattern maps. And this means that you take the lesion from a CT or an MRI, and you overlay that on a normative white matter atlas, and it will then isolate all the connections that are very likely affected by the lesion. Now you can then run a PCA on that and identify disconnectome components, which in our case was 46. And we then basically combine it to decode the white matter that significantly contributes to the group level reading fMRI maps. And the results are like this. So on the top, you see the classical fMRI analysis. And then the critical white matter that was identified by this analysis is the vertical occipital fasciculus in the occipital lobe that has been implicated for reading, and U-shaped fibers right here connecting the midfrontal and the precentral gyrus close to Exner's area. And then we were also able to identify a lesion that would result in a reading deficit, even though this type of lesion is quite rare. And that's what you see at the bottom. Now, in this study, we obviously took fMRI lesion data and tractography data quite separately. So the next step then was to come up with a smarter way to actually combine it rather than just statistically associate it. And that's the work of Victor Nauzas, who did his PhD in Bordeaux with us. And he developed a software toolkit called the Functionectome. I know the name is not ideal, but it's done now, it's published. And what this software does is it takes the time series fMRI data and it projects it onto the white matter. It's freely available online, and we also have a tutorial on the YouTube channel if you want to try it. I have to warn you though, the tutorial comes with very cheesy French elevator music. Now, what can you do with it? Here are some examples. So I think this was a finger tapping task that I'm showing you here. So you have the functional activation at the bottom, and then the functionectome analysis identifying the corticospinal tract as the white matter supporting this particular function. Now, Victor then went on to separate his prior. So initially you had the whole brain, and then he split it up into association, commissure, and projection fibers. And that means that you can now run the software and get results specifically to association fibers connecting areas within the same hemisphere, commissure connections between the left and the right hemisphere, or projection fibers connecting the cortex to subcortical regions. And he was very productive, so he didn't stop there. He also developed a method along the same lines for resting state data, which obviously is quite useful if patients can't perform a task. And he tested that in a sample of 130 stroke patients, showing that if a lesion affects the resting state network, so the higher, the more damage, then that will result in language deficits, both for comprehension and production. Now, from those validation studies, we then went on to now apply the functionectome to language and speech data that we have at the Dondas, and I'd be happy to tell you more about the language and interaction data that is forthcoming. But for now, I have some preliminary results for you in terms of speech monitoring. So Muge in my lab, a postdoc in my lab, recruited 23 healthy participants, put them in the scanner and had them listen to their own speech with a delay or not a delay, and manipulated the pitch. And the results that we found was that for the fMRI activations, we get the inferior frontal gyrus, the inferior parietal, and the superior temporal. And when you run the functionectome, you nicely pick up the arcuate fasciculus here and the frontal aslan tract, which would make sense given that they hear their speech, they have to process it, but they also have to talk themselves, and that's where the frontal aslan tract is coming in. So this seems to work quite nicely. Now, another part that we did in the reading study was using lesion data. And this is work by Leah Talozzi in our lab, who developed the Disconnectome Symptom Discoverer. Again, quite a mouthful. You find it on this link. And what this lets you do is it takes the lesions that were delineated again on CT or on MRI scans, you upload it and it generates the disconnectome map for every lesion. And she did that with the 1,300 stroke patients, created what's called a morphospace. So it's an embedded space that shows where all the patients land. And we had their 1-year follow-up data. So we know who recovered, who didn't recover, and to what degree. And what you can then do is use your own data, upload just the lesion mask, get the disconnection of that individual patient, project it into the space, and get a prediction of the recovery at 1 year. And then you can just download your statistics, the map, and the statistics behind it, and analyze it. And Thomas Hope and Kathy Price also used that method on their Plurus data as an out-of-sample validation in language as well. Now, another exciting thing that we could do with that kind of data is to bring it back to the white matter. So this is probably an image you're less familiar with. It's an axial slice through the brain, but instead of seeing the gray matter cortical areas, what you see is all the white matter connections. And we were able to identify which part of the white matter is relevant for which clinical tests. So in the DSD, you have about 86 clinical assessments of cognition and behavior. And we're currently writing an atlas, a book, where you have the full range of maps for every slice of the brain. Now, that's the clinical side of it. Valentina Pasella, also a postdoc in our lab, had a fantastic idea a while ago where she was interested in mapping all the functions that we know. Now, when you start off with that idea, it's like, how do you do that? So the way she conceptualized the study is that she used NeuroSynth, which is an online meta-analytic database that has a lot of the fMRI studies that were conducted. And there was 2 releases. One was in 2017 and one was in 2021. So she used the first release in 2017, which has 506 terms for functions. She parcellated it and then did an embedding of all the functional data that is available. And the result looked a bit like a neuron, where we see that some of the functions that we map center or cluster in the center of this graph, while some of them have their own independent branches here. Now, what that means is that when you have your own branch and the color coding is brighter, then there is a good conceptualization behind that particular function, whereas all the functions that cluster in the middle are less confined or less coherently defined in the field. So if we zoom into our language branch, then we see that these concepts are quite well defined in the field. And to give you an example about the concepts that are less well defined in our field, we have feeling concepts. Cognition is somewhere in there as well. So this is the space of the 2011 release. And then she wanted to see if we can predict the new maps that were added in 2021. So we downloaded the data. We also downloaded additional data from NeuroQuery and NeuroWorld, same idea. And what she could show is that we can actually predict the new maps quite well based on this embedded space. Now, while this is the technical side of the project, the really exciting bit about this project is not the data that I'm showing you, but the data that's not there. And that is that we have a lot of gaps in our map. And that indicates that there's probably quite a bit of functions that we haven't mapped yet. So here's my call for you. Go out there and fill the graph. Find the functions that we haven't mapped yet at the intersections between the individual dendrites, for lack of a better word. Right, so where does that leave us? We recently tried to summarize all this in a review paper where we argued that the classical localizationist approach to language in the brain, or the modular model of language in the brain, is probably insufficient. It doesn't give us enough flexibility for a complex function like language in the brain. So that model here on the left is probably insufficient to capture language as we know it. The same holds for the hierarchical model, which is the classical arcuate model that I'm showing you. And if we take repetition, then you have the hierarchy where first you have to hear and understand, and then propagate that information to articulate. So what we propose in this paper is that language probably relies on integration within the language system and beyond. And that gives rise to language as an emergent function. Now, that may or may not be a complex idea for you, but I struggle to wrap my head around it, how to really capture the essence of that. And the best example that I could come up with is that if you ask me where language is in the brain, it's similar to asking an orchestra where their music is. It's not in the individual instrument, not in the individual notes, it's not in the conductor, it's in all of them coming together in a timely fashion that their music emerges. And that's how we believe language in the brain works as well. And with that, thank you very much.
Wow, thank you so much for a enlightening, entertaining, fascinating talk, and communicated in such an accessible way. So thank you so much. Questions, please.
Hi, Stephanie. This is great. I really loved it. I've got one question about how do you envisage in future, or maybe you're already doing it, integrating the non-binary, because now it's lesion or not lesion, right? It's either a mask or not a mask. What about the things like white matter disease and degradation of atrophy? You're assuming healthy brain aside from the lesion. How do you bring them together?
It's not an easy question. But there's various different angles you can play. So going beyond the lesion is where we're currently at, right? We're looking at the white matter that is disconnected, but we're looking at it again in a quite dichotomous way. Is it disconnected? Is it not disconnected? Or to what degree is it disconnected? What we're completely missing is the information, what's actually in there. What's the physiology of that connection? Is it functional? Can we extract other measurements? So ideally, and I've been saying this for 10 years, we're still not there. I would like to combine the post-mortem information that we can get and the in vivo information that we can get to really get more out of the white matter than just a nice visualization.
That's Kathy and Dorothy. I'm not sure who was first.
Yeah, thank you very much for the great presentation and the really great developments. So I just have a question to your fiber model on language processing. So I missed the extreme capsule as the ventral pathway connecting the temporal lobe with the prefrontal cortex, especially the inferior frontal gyrus. So it's identical to the anterior part of the inferior fronto-occipital pathway or to the uncinate fascicle?
So it's classically considered to be part of the IFOF, and the difference really comes from the cross-species studies. But the uncinate has a different trajectory because that is really arching down into the anterior temple. So if anything is part of the IFOF.
If there are time for 2 more questions, I'm happy to pass to Fatima first. Okay. Absolutely brilliant talk, Stephanie, as always. And congratulations on the prize, so well deserved. I love your conclusion that language is an emergent property. And it, I've advocated the same for a very long time, but it's become very unfashionable. So I'm very happy to hear you as a prize winner here singing out for that makes the most sense in how we integrate what we know about language involving multiple different cognitive functions. But how do you face criticisms which are challenging, which come from, for instance, the Eva Fedorenko group and also from Stan de Haan and others, that this specificity depends on also our spatial resolution, and that what maybe we're missing are unique areas that we have not yet been able to look at. That would be in the case for Stan de Haan followers. And with Eva Fedorenko, she's making very strong claims that these are language specific and that language is separate from thought. and there's strong movements. And so I'm sitting back, watching what's happening and trying to understand where we're going, and possibly accepting that, we're wrong. There's certainly a big debate now coming through. I'd like to know how do you combat those sorts of arguments?
You're throwing all the easy questions at me. So I agree that there is a debate, and when we published the paper, we basically had two feedbacks. One was, this is outrageous. And the other one was, well, this is not new. We knew that. Yeah. And there was nothing in between. So you have that dichotomy. And
goodness, for the other reviewer to demonstrate to the editor that there's a debate there that you're contributing to. Yeah.
And it's true, we didn't invent language as an emergent function. We just put it together, and it's the most logical result given the data that we have, especially the clinical data. Now, I'm not saying that integration is the only way it can work. There has to be some hierarchy in language processing. So it's probably not the extreme modular view. It's probably not the extreme emergent view. And it's more a combination of the two, but rather on the emergent property side, because clinical data is challenging the high specificity, the individual areas that are needed. If you speak to a neurosurgeon, they say they can take out the inferior frontal gyrus and not much happens. So we also have stroke patients who have a lesion there, don't present with Broca-like aphasia, and patients who have a lesion somewhere else, but do present with that type of aphasia. So the clinical data doesn't really support the very strong modular view of language in the brain. But I'm actually debating her in August, so we see how that goes.
Argue that patients where you detect the aphasia, so if you take something like pure alexia, and sorry, I don't want to dominate this with but people argue that it's specific, but again, it depends on whether you test how much detailed testing you have. And the same with the activations in the brain. People can claim this specific, but until they've tested, a wide variety of other functions, you don't see that it's involved in other things. You can actually never prove that it's specific because it depends on what you haven't tested.
Yeah, that's also where Valentina's work came in quite nicely, to see what we have and haven't tested yet across the fMRI literature. And in terms of the specificity, when we look at the anatomy, for example, the scans that we're working with are an approximation of where we are, right? It's not the true anatomy. But I don't think that having more and more resolution will solve that issue, because we're just going smaller and smaller. And then we have a measuring and a mapping problem in the end. If you look at tiny, tiny voxels, which from an anatomical point of view is super exciting. And I'm very much looking forward to the new scanner we're getting at the Donner's that is 14 Tesla. The resolution will be mind blowing. And the anatomist in me is super excited about it. But the language person in me, I don't think it will help us much to go smaller and smaller.
I agree. Thank you again.
Thank you, Stephanie. That was as entertaining as your debate in 2015, which was also equally fun to watch. I had a question about the applicability of these atlases, whether the older ones or the much more kind of new ones, into the patient population that we study who are older, they've got atrophied brain, the ventricle is triple the size of the normal atlases. Do you think they're applicable? And do you think there needs to be a need for doing aging of the white matter atlas and kind of have an atlas for each decade of life, for example?
Absolutely. The more specific you can be and the closer you can be to the sample that you're interested in, the better it is. The way we developed our tools is that they're completely open. So you can always put in your own atlas and maps if you have them. And there is a lot of work. There's a paper that's just a preprint now from Kurt Schilling, where they actually looked at the longitudinal development of white matter measurements from the early days towards the later stages. So that, it's a good idea to match it. And also not just across the lifespan, but also across cultures. Because we know that brains in different parts of the world are slightly different shaped, and we completely ignore that in our analysis.
Got time for question? There is, yeah. Wait until I went all the way over there.
So a classical parsing of stroke syndromes in neurology is between subcortical and cortical being associated with cortical signs.
Mhm.
Now, the implication of what you're saying is that cortical signs can be a consequence of a primary white matter injury. I wonder whether you ever consider the possibility of actually examining a different disease, let's say a disease that is primarily white matter, in order to get a better handle on sort of the causal relation between white matter injury and cortical signs that is somewhat confounded when you look at cortical strokes, which is probably what you mostly are looking at.
That's true. That's mostly what I'm looking at, but I also looked at primary progressive aphasia, where you have a degeneration over time in the cortex and the white matter.
Degeneration, right?
Correct.
It's secondary, it's not primary.
But it's hard to find really pure white matter lesions that will not impact the cortex at some point. So you have to find the right timing. Just like for the cortical atrophy, at some point it will impact on the white matter. So disentangling the white matter and the gray matter, I don't think is the way we should be. Like, that's what we've been doing for many years, that we went in isolation. And I think it's time to bring it together and actually look at both in combination.
Okay.
Sorry. Thank you. Apologies to delay lunch. What's your thoughts on NODI kind of analysis and looking at white matter with that kind of tool with microstructure?
I have an entire talk on that, but it's a valuable method, and it gives you additional information, getting closer to combining it with other types of microstructural information. So it's a worthwhile method to use.
Great.
But there's a plethora of tractography methods out there, and some of them are better, some of them are worse for different reasons. So it really depends on the question that you want to ask, which method is the best for you in that case.
Thanks. Okay, so thank you once again, and also it's a great pleasure that we have Professor Elizabeth Warrington joining us in the auditorium. So I'm hoping maybe that at the end we can have a photograph with you, Professor Warrington, and up here on the stage. That's fantastic. So just bring this morning session to an end. Lunch, and please do take time to look at the posters which are on display, and we will resume at 1 o'clock with the continuation of our guest symposium. So just join with me once again to thank Stephanie for the most remarkable